Dr. Tan Yia Swam, your 3 cards, please.
Mr. Chairman, I declare my interest as a breast surgeon in private practice and my role as the elected president of the Singapore Medical Association. Today, I want to talk about the heart and soul of healthcare. I'm gratified to see many MPs speaking up for healthcare workers over these recent years, and I hope that you will continue to do so, because who heals the healer? After 3 years of fighting COVID, healthcare workers are burnt out. Many feel overworked, underappreciated, even trapped with no way out. Let me share from my personal and professional experiences on 3 key areas for parliamentarians to consider. 1, why we chose to enter healthcare. 2, how circumstances are interfering with delivery of care. And 3, how can you help? Many of us entered healthcare because we wanted to help people. Many were inspired by healthcare workers who attended to our own loved ones in their time of need, and we also want to do the same. A handful perhaps are street smart and see that being a healthcare worker provides a comfortable and steady income. But I believe most of us had the calling to serve. However, along the way, many of us got jaded. Some of my doctor and nursing friends have said they would never allow their children to follow in their footsteps. It is too hard. I don't want them to suffer like I did. People see the glamour of being a doctor. Maybe they see the top 1% who are earning very well. And even here in this house, the perception of the overcharging doctor is prevalent. Yet, do you know the junior doctor who is the sole income earner, looking after his elderly sick parents, a disabled sibling, and starts off his career with a large student's loan? Do you know the doctor-nurse couple struggling with infertility because they were too busy, too stressed to try for family during their training years when they work shifts and 100-hour work weeks? Do you know the solo practice doctor struggling to maintain a viable business because of increasing manpower and rental costs and falling prey to unfair corporate insurance contracts? I know there are some really bad doctors out there. Of course I do. The newspapers, social media are full of these reports. But the rest of us, we have no outlet to share our woes, our struggles. Secondly, the practice of medicine has changed. Not just the medical aspect, but the social and legal aspects. We face stresses and problems which the general public is not aware of. Changes in specialist training systems, electronic records which are no better than paper documents placed online, the use of multiple and sometimes duplicate checklists in the name of patient safety, increasingly strangulating regulations while complementary health services flourish with no checks or balances. I will speak more in my later cut. Imposition of KPIs which drown out what I feel is the most essential to be a good clinician. We as a society have also changed. We lost the ability to listen, to empathize. We have short attention spans, quick to take offense, quick to judge. I blame social media, allowing baseless accusations and falsehoods to be amplified by anonymous keyboard warriors. When healthcare is managed as a business, healthcare workers become mere service providers with a fee for service. Patients become customers, expecting customer service. Some have self-diagnosed and demand a treatment which they Google online because they perceive that 20 minutes of Googling is more significant than 20 years of your experience. Doctors adopt defensive medicine. You have all heard about these concerns in October 2020 in the second reading of the MRA bill. The more senior I get, the more artificial barriers I find between me and real patient care. Third-party administrators, insurance restrictions, the cancer drug list, reimbursement limits for various schemes. I've spoken on these before and will elaborate on some of these in my later cuts. It is this deep sense of unease that is poisoning our entire healthcare ecosystem. My gut feel is we complain about tangible things, asking for more pay, more leave, because we couldn't quite express just how sick we feel. Well, I've just tried, and unless we treat the illness and not just the symptoms, no amount of pay will ever give us back the joy we once had. So finally, how can you all help? Rather than more legislation, I'm asking for understanding. I ask for kindness. Help us to help you. The next time a healthcare worker complains about the system, listen. Truly listen with your heart. The next time a healthcare worker quits and walks away, take the exit interview seriously. In the next round of engagements, listen past the naysayers to the core issues which are bothering us. Help us with public education, how to navigate the local healthcare system, how to best utilize your private insurance plan. I intend to lead the SMA in collaboration with CASE to jumpstart this. Help us re-establish respect for all healthcare professionals. patient service associates, audiologists, dietitians, medical social workers, lab technicians, podiatrists, couriers, to name but just a few. Help us with IT challenges, help us reduce unnecessary paperwork, protect us from undue influences by market forces and business entities, recognize and call out abusers. Recognize mental health issues in yourself. If you suffer from anxiety or anger management, don't take it out on your healthcare worker. Get help from a mental health professional. I ask each and every one of you to be understanding, to be kind, and help us to help you. Sir, my second card. During my surgical training years in SGH, I had this highly principled and no-nonsense trainer called Dr. Koh Poh Kun, now Senior Minister of State for Manpower. I regard him as a man of wisdom and insight and a mentor to me professionally. On 29 November 2022, he rejected a proposal by the General Insurance Association. He said GIA's suggestion of using only existing prolonged medical leave insurance or group personal accident insurance in place of WICA would relegate this to a private insurance policy whose terms and conditions are dictated by the insurer without a clear mechanism to adjudicate disputes. I do not think we should be leaving it to insurers to be the final arbiter of any disputes to work injury claims, citing possible conflicts of interest. And once again, I learned something valuable from him, as I often had in the past as a surgical trainee, the concept of final arbiter. There is no final arbiter in the integrated shield plans, or IP for short, when clinical matters are involved. MAS is the final arbiter for matters pertaining to the financial viability of insurance companies in Singapore, including IP providers, but regrettably, they do not deal with clinical matters. Currently, there is a Clinical Claims Resolution Process, CCRP, of which was one of the solutions presented by the MHIC, of which I am an appointed member. It is a platform with great potential in which patients, IP providers, and healthcare providers, both doctors and hospitals, can take part in when disputes arise due to clinical issues. But the CCRP is a voluntary process, and it falls apart when any one party does not wish to participate. In other words, it has no teeth, and it is no final arbiter. Will MOH consider annual updates on the number of CCRP cases that have been filed? In addition, to state how many cases could not proceed because one or more of these parties refused to take part, and who the refusing parties were. So, who should be the final arbiter for clinical matters in IP policies and claims? Could there be a law to directly compel IP providers to cover and reimburse healthcare services in line with acceptable clinical practices or even best practices? Let me tell you about patient Mr. B. He had a colon cancer which was operated on several years ago. On follow-up, his oncologist found an abnormal lymph node near the armpit, which he thought was a relapse of the first cancer. A core needle biopsy was done to sample the lump, and the result was normal. However, 6 months later, the lump grew larger and looked worrying for a different kind of cancer, lymphoma. Mr. B was then referred to me for surgical biopsy. This is a surgery to remove the lump for complete testing. I was a doctor on the patient's insurance panel and completed the pre-authorization process. However, the problem came later on when even the lab couldn't make a clear diagnosis and needed to send to another, even more specialized lab for a second opinion and additional complex immunohistochemistry tests. The lab needed payment prior to doing the test, and the patient should pay first and reimburse later, but he declined to do so as he had limited cash flow and was worried the insurers would not reimburse him, despite assurance, written assurance that he would be. So in the end, I had to circumvent the issue and ask Mr. J, one of the senior managers I know in that insurance company, to help with this. On the back end, he personally attended to the case and helped the patient to have cashless payment and got the test done. A few months later, I was asked by the insurance administrator to explain and justify why the second opinion was needed. I checked in back with Mr. J. He noted the duplicate request and had it withdrawn. Long story, I know, but now you understand why doctors complain so much about paperwork and insurance. Thankfully, this case had a happy ending. This was possible only because of mutual trust. Mr. B trusted his oncologist to recommend the appropriate surgeon for a necessary surgery, and Mr. J trusted me that my medical judgment was sound and my explanations were adequate. However, how many patients or doctors enjoy such a relationship with their insurer? I propose 3 solutions. 1, insurers can approach a professional body to provide training to the administrators to better process clinical claims. 2, maybe there should be an on-call agent, much like how hospitals have an on-call doctor to attend to any emergency, and this agent will help the clients to navigate the paperwork stat. 3, perhaps there needs to be a new specialty, a clinical insurer, a medical doctor who changes track mid-career and bring a wealth of clinical knowledge into how insurers should work. Finally, I want to put on record my personal appreciation to the MOH Deputy Secretaries and staff in leading the MHIC, who have been instrumental in bringing together various stakeholders to a common table and work for the greater good. Sir, my third card. As our population grows older, more people will be diagnosed with cancers. As medical technology advances, there will be newer and better drugs for cancer care, which are costly. The MOH Cancer Drug List, CDL, dictates which drugs will qualify for subsidies and Medisave coverage. IP providers have also upgraded their coverage and claim limit terms. As a breast surgeon in private practice, most of my patients with breast cancers will be referred to medical oncologists for systemic treatments. These include chemo, targeted, and immunotherapy. 65% of Singaporeans have IPs, and we bought them with the expectation that when a catastrophic disease like cancer strikes us, we can proceed with treatment in the private sector, where we get to choose the doctors that we are comfortable with, have faster access to treatments, and be able to afford it. Let me run through some numbers. The 2022 median monthly household income was around $10,000. Using the latest available SingStat survey on household expenditure ending 2018, I extrapolate. Monthly expenditure all in was around $5,800. In the report, the monthly housing rental is around $1,000. In current times, monthly rental may range from $2,000 to $3,000, so the surplus may be about $2,000 to $4,000. In this family, if someone has cancer and needs treatment, the financial implications are sobering. Potential loss of job and loss of income. Even with a shield plan, if the out-of-pocket payment exceeds, say, $3,000 a month, not just for drugs, but for all services, such as consultation fees, investigations, and non-cancer drugs to treat the side effects of therapy, then perhaps this patient may opt for subsidized care in a restructured hospital, even though he or she has private insurance. In itself, this is fine, and I have often vouched for the high-quality care in restructured hospitals. But it begs the question as to whether the policy intent of IP is met, which is that insurance will make private services affordable to more people through risk pooling. Should there be a big shift of patients to the public sector, it will lead to a further strain on the system, with longer waiting times for appointments and treatments. Also, don't forget that the subsidies are ultimately paid for by taxpayers through the MOH budget. Singaporeans should be strongly advised that having an IP does not mean that private healthcare will necessarily be affordable when it comes to cancer care. It is a tragic and stressful situation to have a double whammy of receiving a cancer diagnosis and then finding out that they actually cannot afford cancer care in private because the IP coverage is inadequate. I hope MOH can use existing bill sizes and conduct a large-scale study of the out-of-pocket payments for cancer treatment for IP policyholders under the new terms for CDL versus non-CDL drugs, should they opt for private healthcare. I pose several issues for thought. The insurance industry is heavily regulated and I respect their work, yet I am mindful that they are business entities who need to be profitable, yet keep premiums affordable. Public expectations of what our IP plans can cover have to be managed. Out-of-pocket payments by patients need to stay affordable. Limited public health care resources have to be managed prudently. These are difficult issues and we need to think carefully about them. How many patients on private insurance will still not be able to pay for drugs and have to go to the restructured hospitals for care? And how many may never be able to afford the so-called better medications? How will this affect long-term cancer survival rates? This will be a hard lesson for all of us to learn and to accept the practical limits of what we collectively and individually can afford.